Welcome to our YouTube lecture series on anomalies of tooth formation and eruption. Today, we delve into the intricate world of dental anomalies, exploring various deviations from the norm that can occur during the development and eruption of teeth. From missing teeth to abnormalities in size, form, and structure, we'll uncover the fascinating array of anomalies that can affect the dentition. Our journey will take us through a comprehensive exploration of anomalies such as missing teeth, extra teeth, abnormalities in tooth size and form, and the presence of accessory cusps, invaginated, and evaginated teeth. We'll also unravel the mysteries of Taurodontism, Enamel, Dentine, and Cementum defects, shedding light on the underlying causes and implications for dental health. Join us as we embark on this educational journey to deepen our understanding of anomalies of tooth formation and eruption, empowering ourselves with knowledge that is essential for providing comprehensive dental care. Let's dive in. Missing teeth. Terminology. Hypodontia, missing teeth due to developmental failure. Anodontia, total absence of teeth in one or both dentitions. Oligodontia, multiple missing teeth, usually more than 6. Prevalence. In primary dentition, maxillary lateral incisor commonly affected. Prevalence ranges from 0.1% to 0.9% in Caucasian populations. In permanent dentition, third molars most commonly missing. Prevalence between 3.5% and 6.5% excluding third molars. Female to male ratio, 4:1. Etiology. Genetic origin is common, may also result from environmental factors. Associated with multiple births, low birth weight, and maternal age. Syndromes like X-linked hypohydrotic ectodermal dysplasia and Down syndrome linked to missing teeth. Gene mutations implicated, MSX1, PAX9, and sonic hedgehog, SHH. Treatment. Requires multidisciplinary approach, pediatric dentists, orthodontists, prosthodontists, genetic counseling. Active preventive care. Composite restoration advised for small or conical teeth. Full dentures for anodontia, implants may be an option in adulthood. Partial dentures for multiple missing teeth, implants later in treatment. Implant placement after skeletal maturity. Dentures require periodic replacement and modifications to mimic developing dentition. Implant retention may be limited due to underdeveloped alveolar bone, single gene disorders, and missing teeth. Associated with various syndromes. Manifestations. Multiple missing teeth. Teeth with small crowns. Syndromes associated with multiple missing teeth and small crown teeth. X-linked hypohydrotic ectodermal dysplasia. Characterized by thin sparse hair, dry skin, absence of sweating, and multiple missing teeth. Autosomal dominant and autosomal recessive cases of ectodermal dysplasia. Ectodermal dysplasia involves defects in the development of 2 or more ectodermal structures. Autosomal recessive chondroectodermal dysplasia Ellis, Van Creveld syndrome. Characterized by short limbs, polydactyly, and congenital heart defects, along with dental abnormalities. Down syndrome, trisomy 21. Associated with hypodontia, among other characteristic features. Manifestations. Missing teeth. Teeth with small crowns, hypodontia and microdontia. Occur in clefts involving the lip and palate. Specifically involve the maxillary lateral incisor. X-linked hypohydrotic ectodermal dysplasia, XLHED. Mainly affects males. Characteristics: thin sparse hair, dry skin, absence of sweating leading to heat intolerance, multiple missing teeth. Risk: inability to cool themselves, leading to hyperthermia and potential death in infancy if undiagnosed. Importance: dental professionals may be the first to diagnose. Introduction to support mechanisms for families. Manifestations in heterozygous females. Milder changes, often restricted to the teeth. Distinctive facial profile, slight protrusion of the maxilla may be present. Common dental findings: one or both maxillary incisors and/or second premolars are missing. Maxillary lateral incisors may be of peg form in some patients. Responsible gene: ED1 gene on the X chromosome. Encodes the protein ectodisplacin A. Extra teeth, supernumerary teeth. Prevalence: primary dentition, 0.2 to 0.8% in Caucasians. Permanent dentition, 1.5 to 3.5% in Caucasians. Male to female ratio, approximately 2 to 1. Types and characteristics: supernumerary primary teeth may lead to supernumerary permanent teeth. Supplemental teeth resemble normal teeth, while accessory supernumerary teeth have atypical forms. Mesiodens, supernumerary teeth located in or near the midline of the anterior maxilla. Paramolars and distamolars, supernumerary teeth in molar regions adjacent or distal to the normal sequence. Some supernumerary teeth may manifest as odontomes. Location and symmetry: more common in maxilla than mandible, ratio, 5 to 1. Bilateral and symmetrical presentation possible, prompting consideration for additional supernumeraries in other jaw regions. Impact and associations: supernumerary teeth may impede eruption of permanent teeth, especially mesiodens. Association with invaginated teeth and palatal clefts, with approximately 40% of anterior palate cleft patients exhibiting supernumerary teeth. Multiple supernumerary teeth seen in cledocranial dysplasia, oral, facial, digital syndrome type 1, and Gardner syndrome. Abnormality of tooth size. Crown size. Subjectivity exists in defining normal tooth size. Larger than normal teeth, megadont or macrodont. Smaller than normal teeth, microdont. Crown size often correlates with root size. Associations. Microdontia can accompany hypodontia, such as in X-linked hypohydrotic ectodermal dysplasia. Megadont teeth result from fusion of adjacent tooth germs or gemination, attempted separation of a single tooth germ. Counting teeth determines the nature of the abnormality, reduced number for fusion, normal/increased number for gemination. Commonly affect permanent maxillary central incisors and mandibular second premolars. Isolated megadontia in permanent dentition occurs in approximately 1% of patients. May be symmetrical or associated with conditions like pituitary gigantism, unilateral facial hyperplasia, and hereditary gingival fibromatosis. Microdontia. Prevalence. Primary dentition, uncommon, prevalence of 0.2 to 0.5%. Permanent dentition, prevalence of approximately 2.5% for individual teeth, with generalized microdontia in around 0.2% of individuals. Females more frequently affected than males. Maxillary lateral incisor commonly affected, presenting with peg-shaped or conical crown. Associations. Associated with hypodontia. Root size. Racial variation. Oriental background, shorter roots observed. African origin, larger roots typically seen. Large root size. Permanent maxillary central incisors commonly affected. Prevalence, 2.3% in one Swedish. Male prevalence 4 times higher than females. Small root size. Short-rooted primary teeth may accompany other dental abnormalities. Conditions affecting dentine and/or pulp may result in short roots. Prevalence of short-rooted permanent maxillary central incisors, 0.5% in children. 15% of these may have short roots on other teeth, often premolars and/or canines. Cause often unknown, orthodontic treatment may contribute. Other factors. Regional odontodysplasia, abnormal root formation and crown abnormalities. Irradiation or chemotherapy during root formation may lead to root truncation. Treatment. Multidisciplinary approach involving pediatric dentist, orthodontist, and restorative dentist for treatment planning. Options for megadont maxillary central incisor: acceptance, remodeling, extraction with orthodontant if needed, followed by space masking with bridge, denture, or implant. Microdont tooth treatment, acid etch, composite material addition to reproduce typical crown contours, porcelain veneers or crowns in adulthood. Continued use of composite may delay restorative cycle and tooth loss. Abnormality of tooth form. Abnormality of crown form. Fusion of adjacent tooth germs. Gemination, attempted separation of a single tooth germ to form two separate teeth. Prevalence in primary dentition, 0.5% to 1.6% in Caucasian populations. Prevalence in permanent dentition, 0.1% to 0.2%. Equal male to female distribution. Clinical manifestation varies, ranging from minor notch to two separate crowns with a single root. Mandible more commonly affected than maxilla, especially in dentition. Association with hypodontia possible. Physiological root resorption may be delayed, leading to delayed eruption of permanent successors. Treatment. Primary dentition, no treatment required, but consider potential abnormalities in permanent dentition. Prevent caries develop crown interface with etch-retained sealant or restoration. Permanent dentition, treatment decisions based on factors like available space, pulp/root morphology, and degree of attachment between crown parts. Options include retention, extraction, surgical division, or other treatment. Accessory cusps. Occurrence. Extra cusps are common in both primary and permanent dentition, mostly affecting molars. Primary dentition, accessory cusps often on mesiobuccal aspect of maxillary first molar or mesiopalatal aspect of maxillary second molar, similar to cusp of caries. Permanent incisors may have additional cusps from cingulum, known as talon cusps, commonly affecting maxillary central incisor. Permanent canines may exhibit prominent lingual/palatal cusps, resembling premolars. Additional cusps may occasionally appear on premolars. Prevalence. Cusp of Carabelli, seen in 10 to 60% of various populations. Talon cusps, commonly affect maxillary central incisors. Consequences. Talon cusps may interfere with occlusion and aesthetics. Caries may occur in groove, between cusp and palatal surface of incisor. Treatment. Talon cusps may require action for aesthetic and occlusal reasons. Options include selective grinding over time to reduce cusp height and promote deposition of reactionary dentine, or single-visit sectioning of cusp followed by elective pulpotomy. Invagination of teeth. Prevalence. Uncommon in primary dentition, estimated to affect 1% to 5% of different groups in permanent dentition. Males more commonly affected than females, ratio 2 to 1. People of Chinese ethnicity reportedly more commonly affected. Consequences. Invaginated teeth may lead to caries and pulpal pathology. Problems can arise soon after eruption, with acute abscess or facial cellulitis. Radiographs typically show incomplete root formation and periapical rarefaction. Presence of one invaginated tooth warrants creation of contralateral or adjacent teeth. Treatment. Early identification post-eruption, etch-retained resin sealants to prevent caries development. Acute infective episodes, incision and drainage of abscess, along with appropriate antibiotic therapy. Treatment options. Opening and management of tooth, or extraction if prognosis is poor, especially with gross examples of abnormal crown and root form. Less extreme cases may undergo endodontic treatment, potentially involving apexification. Evaginated teeth, dens evaginatus. Occurrence. Commonly affects premolar teeth, occasionally permanent molars. Characterized by small tubercle on occlusal surface, often in central part of fissure pattern. More prevalent in patients of Chinese descent, estimated at 1 to 4%. Consequences. Evaginations prone to fracture or erosion from normal wear, leading to pulpal exposure, pathology, and periapical involvement. Treatment. Radiographic evaluation essential to assess pulpal extension into evagination. Options. Restricted and regrinding of tubercle to promote reactionary dentine deposition on pulpal aspect, applicable in select cases. More commonly, removal of tubercle and limited pulpotomy may be required. Abnormality of root form. Taurodontism. Definition: enlarged molar teeth with vertically expanded body at the expense of roots. Normal constriction at the amelocemental junction is often reduced or absent. Mechanism: results from late or failed invagination of Hertwig's root, altering root formation mapping. Furcation is displaced apically. Variability in degrees observed, from mild to extreme, including single-rooted teeth. Described shapes include pyramidal, cuneiform, or fused. Clinical implications. Altered root canal morphology, complicate odontic treatment or extraction. Predominantly seen in permanent dentition. Prevalence varies, reported at 6% for mandibular, first permanent molars in British schoolchildren. Higher prevalences observed in certain racial groups, such as Bantu in South Africa. Inheritance, some cases an autosomal dominant pattern within families. Associations, linked with conditions like amelogenesis imperfecta, trichodontoosseous syndrome, ectodermal dysplasias, and X-chromosomal aneuploidy. Considerations, regarded as an atavistic trait, indicating a reversion to ancestral dental morphology. Accessory roots. Occurrence. Can occur in almost any tooth. Primary dentition commonly affects molars, but can also occur in primary canines and maxillary incisors. Permanent dentition, occasionally seen in maxillary incisors, mandibular canines, premolars, and others. Accessory roots often located on distal lingual/palatal aspect, varying in shape, and may be challenging to identify radiographically. Prevalence. Primary dentition, reported at 1 to 9%. Permanent dentition, reported at 1 to 45%. Associations. Associated with large cusps of Carabelli on maxillary first permanent molars, and with accessory cusps on maxillary second and third molars. Presence of accessory roots may reflect macrodontia in some cases. Arrested development of tooth germs. Causes: external influences like trauma, radiation, osteomyelitis, or chemotherapy. Result: leads to enamel defects in developing crowns and stunted root development if the insult occurs during root formation. Turner teeth. Cause: infection from overlying primary predecessor. Characteristics: enamel hypoplasia and/or hypomineralization, commonly affecting mandibular premolars. Regional odontodysplasia. Description: a rare anomaly affecting both primary and corresponding permanent teeth within a dentition segment. Affected teeth. Anterior teeth are more commonly affected, and the defect may cross the midline. Radiographic appearance: term ghost teeth used due to poorly developed crowns, enamel/dentine changes, large pulp chambers, and open apices. Treatment often involves tooth removal. Management of affected permanent accessors is required. Approaches: reports of effective use of etch-retained restorations, but slow eruption and frequent infection risks. Treatment planning: case-by-case planning needed. Block removal of unerupted teeth with surrounding bone is not usually required. Enamel defects. Causes: Can result from genetic or environmental factors acting alone or combined. Less enamel matrix production leads to thinner enamel, hypoplasia. Defect in mineralization of enamel matrix proteins results in poorly mineralized enamel, hypomineralization. Hypomineralization, subdivided into hypocalcification, severe, and hypomaturation, milder. Clinical presentation. Combination of hypoplasia and hypomineralization often observed. Enamel hypoplasia. Uniformly thin or grooved/pitted enamel. Hypomineralization. Discolored enamel, typically yellow-brown. Severity determines coloration, more severe equals darker. Hypomaturation, enamel may appear mottled or slightly opaque. Key points. Hypoplasia, deficient matrix volume. Hypomineralization, poor mineralization, amelogenesis imperfecta. Definition. Generalized enamel defects affecting most or all teeth in both primary and permanent dentitions. Genetic origin, often familial history of similar defects. Can present with additional dental tissue and craniofacial structure abnormalities as part of a syndrome. Clinical features. Possible failure of tooth eruption with resorption of unerupted teeth. Regular radiographic review may be warranted. Inheritance patterns. Single gene mutations, autosomal dominant, autosomal recessive, X-linked. Sporadic cases also observed. Prevalence. Population differences, more common in some regions, e.g., parts of Sweden, than others, e.g., USA. Classification. Traditionally based on phenotype, clinical appearance, hypoplasia, hypocalcification, hypomaturation. Some classifications include additional categories, e.g., hypomaturation hypoplasia with taurodontism. Phenotype classifications can be problematic due to intrafamilial variability. Alternative classification based on mode of inheritance suggested. Modern classification includes genomic chemical identity of the defect. Simplified use might categorize patient as autosomal dominant hypoplastic amelogenesis imperfecta, autosomal dominant amelogenesis imperfecta. Inheritance pattern. Clear pattern of inheritance, successive generations affected. Autosomal dominant gene, 50% chance of passing on to each offspring, affects males and females equally. Dentition involvement. Both primary and permanent dentitions are usually affected. Permanent dentition may be more severely affected. Clinical presentations, phenotypes. Enamel may be thin and hard with normal translucency. Thin and discolored with loss of normal translucency. Both hypoplastic and hypomineralized. Normal thickness, but poorly mineralized. Normal thickness, but lacking normal translucency, hypomaturation. Some defects only detectable through histopathological examination. Taurodontism may be present in some families. Anterior open bite may occur in up to 50% of cases. Etiology. Mutations in the enamelin gene on chromosome 4 implicated in some families. Other genes involved in enamel formation also implicated. DLX3 gene mutations on chromosome 17 found in patients with trichodontoosseous syndrome, characterize amelogenesis imperfecta with taurodontism, curly hair, and bone changes. Autosomal recessive amelogenesis imperfecta. Inheritance pattern. Seen in cases of parental consanguinity, such as first cousins. Consanguinity may result from cultural reasons or isolation in communities with limited gene pools. Both carrier parents may be unaffected, but there's a 4 chance of offspring inheriting 2 copies of the mutant gene. Clinical presentations. Enamel hypoplasia and/or hypomineralization. Designator pigmented enamel used for some cases. Epidemiology. Uncommon except in Polynesia, where the mutation is relatively common. A gene on chromosome 2 linked to autosomal recessive amelogenesis imperfecta associated with ocular defects. X-linked amelogenesis imperfecta. Inheritance pattern. Mutation in the amelogenin gene on the short arm of the X chromosome. Affected males cannot pass on the condition to their sons, but will pass it on to all their daughters. Heterozygous females, carriers, can pass on the mutant gene to children of either sex. Clinical presentations. Enamel defects in both males and females. Enamel may be hypoplastic, hypomineralized, or a combination of both. Severity of the condition depends on the nature of the amelogenin gene mutation and the patient's sex. Type typically presents with hypoplastic enamel, plus or minus hypomineralization. Pure hypoplasia or hypomineralization is rare. Profound hypomineralization can lead to teeth that are so soft they appear reduced in size post-eruption. Molar incisor hypoplasia. Description. Mineralization defects affecting the first permanent molars and sometimes the permanent incisors. Also known as molar incisor hypomineralization or hypoplasia, or cheese molars, due to the friable nature of affected enamel. Characteristics. Often asymmetrical distribution, affecting unmatched teeth. Severity varies, with some molars or incisors more affected than others. Incisors typically show demarcated isolated mottling. Potential causes. Childhood infections, specific antibiotics, and repeaters have been suggested, may result from a combination of genetic predisposition and environmental insults. Treatment. Treatment planning should involve careful occlusal analysis, considering the compromised state of affected molars. Preservation of affected molars versus elective removal depends on individuals and cultural attitudes. Early intervention, such as preformed metal crowns for molars and management of incisor defects, is important. Fissure sealants and adhesive restorations may be attempted but can be painful and unsuccessful, especially without local anesthesia. Apprehension toward dental treatment is common, necessitating a sensitive and comprehensive approach. Systemic, chronological, enamel defects. Description. Enamel defects resulting from systemic insults during tooth development. Typically characterized by horizontal bands of abnormal enamel affecting some part of the tooth crown. Features. Chronological pattern of defects, indicating the timing of the insult during tooth formation. Often results in grooves or irregularities in the affected enamel. Causes. Maternal and fetal conditions during pregnancy, including endocrine disturbances e.g., hypoparathyroidism. Infections e.g., rubella. Drugs e.g., thalidomide. Nutritional deficiencies. Hematological and metabolic disorders e.g., rhesus incompatibility. Similar changes may occur in preterm low birth weight infants, possibly related to neonatal intubation. Effects. Primary incisors are typically affected, with the enamel covering the incisal portions of the crowns showing characteristic patterns. Identification. Knowledge of the timing of tooth formation aids in understanding the timing of the insult. Enamel defects may appear as horizontal bands or grooves on affected teeth. These insults during enamel formation can lead to distinct patterns of enamel defects, providing valuable diagnostic clues regarding the timing and nature of the insult. Systemic, chronological, enamel defects. Description. Enamel defects resulting from systemic insults during tooth development. Manifest as bands of abnormal enamel affecting some part of the tooth crown. Often presents as grooves in affected enamel. Systemic causes. Maternal and fetal conditions during pregnancy. Endocrine disturbances e.g., hypoparathyroidism. Infections e.g., rubella. Drugs e.g., thalidomide. Nutritional deficiencies. Hematological and metabolic disorders e.g., rhesus incompatibility. Illnesses during the neonatal period or childhood. Hypothyroidism, hypoparathyroidism. Chronic renal disease. Gastrointestinal disorders e.g., celiac disease. Tetracycline use during pregnancy or childhood. Exanthematous fevers, less common due to medical care. Features. Chronological pattern of defects indicates timing of insult during tooth formation. Incisal portions of primary incisors typically affected. Tips of first permanent molars may also be affected due to development around birth. Excessive fluoride intake can cause cirrhosis, characterized by enamel mottling and opacities. Treatment considerations. Treatment extends beyond mechanical tooth repair. Children may face social challenges due to enamel defects, requiring sensitive handling by professionals. Strategies to address teasing and psychological impact are essential. Preventive measures such as full coverage restorations may be advocated in primary dentition. Localized defects may be managed with simpler measures. Dentine defects. Genetically determined dentine defects. Dentinogenesis imperfecta. Description: autosomal dominant inherited condition affecting dentin formation. Associations can occur in isolation or with osteogenesis imperfecta. Genetic base linked to chromosome 4 and mutations in the DSPP gene. In some cases, mutations in collagen type 1 genes on chromosome 7 or 17. Clinical features. Opalescent hue of teeth, sometimes termed hereditary opalescent dentine. Grayish or brownish coloration of teeth. Variability in severity among family members. Enamel may chip away, exposing dentin. Attrition of crowns, leading to worn-down teeth. Bulbous crowns and shortened, sometimes thinner roots radiographically. Large pulp chambers, which may be obliterated over time. Pathological features. Mantle dentine adjacent to enamel dentine junction is typically normal, while deeper dentine is grossly abnormal. Ehlers-Danlos syndrome. Description: some types involving mutations in collagen 1 genes can present with dentine changes, along with enamel changes. Treatment. Management involves addressing aesthetic and functional concerns associated with dentine defects. Early intervention may be necessary to prevent complications such as pulpal exposure and abscess formation. Treatment strategies may include restorative procedures to address enamel chipping and attrition. Long-term monitoring is essential to address any evolving issues and maintain oral health. Osteogenesis imperfecta, OI. Description: arises from mutations in one of the two collagen type 1 genes. Formerly classified with both autosomal dominant and autosomal recessive inheritance patterns, but now primarily considered autosomal dominant. Severity of the condition varies among individuals and families. Cases previously labeled as autosomal recessive may result from gonadal mosaicism. Clinical features. Bone fragility leading to frequent fractures, even from minor trauma like bumping into furniture. Blue sclera, the whites of the eyes, which is a distinctive feature. Deafness, typically developing around the third decade of life. Laxity of ligaments around joints. Dentinal changes may or may not be present, and if present, they can be subtle and may not be clinically or radiographically apparent. Dentinal dysplasia. Description: also known as rootless teeth, dentinal dysplasia is an autosomal dominant trait affecting both dentitions. While the teeth may appear clinically normal, root formation is abnormal to varying degrees. Some teeth may have extremely short blunt roots, while others are markedly towards the apex. The pulp is partially obliterated, often appearing as a small demolin in molar teeth. Microscopically, the coronal dentine appears normal, but the root dentine shows masses of abnormal dentine obliterating the pulp space, resembling boulders in a flowing stream. Types. Type 1, characterized by abnormal root formation. Type 2, coronal dentinal dysplasia likely represents an allelic variant of dentinogenesis imperfecta, as genetic linkage studies have shown it to map to the same region of chromosome 4. A mutation in the DSPP gene has also been identified in one family diagnosed with dentinal dysplasia type 2. Further research is needed to determine if dentinal dysplasia type I is also allelic to dentinogenesis imperfecta. Vitamin D-resistant rickets. Description: inheritance, X-linked inherited condition. Symptoms in males: affected males tend to be short in stature with bowed legs and other skeletal changes. Dental manifestations: abscesses may form in the absence of caries. Dentine is the most markedly affected dental hard tissue. Histopathological finding: interglobular dentine is the chief histopathological finding. Radiographic features: pulp spaces are larger than normal, and pulpal extensions of the pulp horns may be exposed due to tooth attrition. Symptoms in heterozygous females: heterozygous females tend to be more mildly affected and may not exhibit any dental manifestations. Environmentally determined dentine defects. Local trauma: trauma to the tooth during development can result in permanent records in dentine as prominent incremental lines. Systemic influences. Nutritional deficiencies: inadequate nutrition can impact dentine formation. Tetracycline hydration: the use of tetracycline, especially during tooth development, can affect dentine formation. Chemotherapeutic agents: cytotoxic drugs used in anti-cancer therapy may influence dentine formation. Treatment. Psychosocial impact: similar to enamel defects, dentine defects can lead to severe psychosocial problems due to the appearance of the teeth. Management focus. Dentinogenesis imperfecta: management focuses on preventing tooth wear, maintaining vertical dimension, and improving appearance. Rickets: treatment aims to address the underlying cause and may involve aggressive dental support to bacterial access to extended pulps. Acute management: cases presenting late may require acute management of dental abscesses resulting from pulp death. Cementum defects. Genetic disorders: various genetic disorders can affect the cementum, leading to significant consequences for the dentition. Rare conditions and early tooth loss. Hypophosphatasia: this condition, which can be inherited in autosomal dominant or autosomal recessive patterns, result in premature exfoliation of primary teeth or loss of permanent teeth. Low serum alkaline phosphatase levels and urinary excretion of phosphoethanolamine are characteristic. Histopathological examination reveals aplasia or marked hypoplasia of the cementum, along with abnormal dentine formation including interglobular dentine similar to vitamin D-resistant rickets. Treatment. Local measures: scrupulous oral hygiene practices may help slow the loss of teeth in cases of hypophosphatasia. Replacement of teeth: the primary focus of treatment may involve replacing lost primary and permanent teeth as they are lost. Disturbances of eruption. Variations in timing. The timing of permanent dentition eruption exhibits considerable variation. Racial differences and environmental factors like nutrition and illness can influence eruption patterns. Sex differences. In general, females tend to experience slightly earlier eruption of permanent teeth compared to males. This discrepancy becomes more pronounced with teeth that erupt later in the sequence. Premature eruption. Family trait and birth weight. Some families report a genetic predisposition to early tooth eruption. Children with higher birth weights may experience earlier eruption of primary teeth compared to those with normal or low birth weights. Associated conditions. Early eruption of permanent dentition can occur in children with precocious puberty or endocrine abnormalities, especially those affecting growth or thyroid hormones. Natal and neonatal teeth. Natal teeth, teeth present at birth. Neonatal teeth, teeth erupting within the first month of life. Most commonly, malar central incisors are affected, occasionally maxillary incisors or first molars. Syndromes like Pachyonychia congenita, Ellis, Van Creveld syndrome, and Hallermann-Streiff syndrome may also present with natal or neonatal teeth. Characteristics and risks. These teeth may be mobile due to root development and pose a risk if inhaled. Abnormal crown form and poorly formed or thin enamel may be present. Mobility often leads to inflammation of surrounding gingiva and trauma to the tongue, causing ulceration and difficulty in breastfeeding. Treatment. Local measures like smoothing sharp edges can alleviate ulceration. Extraction may be necessary if the tooth is significantly loose and unlikely to contribute to dentition. Extraction technique involves firm application of forceps followed by local curettage. Delayed eruption. Systemic factors. Prematurity or low birth weight can lead to delayed eruption of primary teeth. Down syndrome, Turner syndrome, nutritional abnormalities, hypothyroidism, or hypopituitarism can also cause delayed eruption of both primary and permanent teeth. Cranial dysplasia. Autosomal dominant condition, characterized by aplasia or hypoplasia of clavicles and cranial changes. Features include delayed or failed eruption of permanent teeth due to the presence of multiple supernumerary teeth, particularly in the anterior jaws. Delayed or failed eruption may also occur due to failure of primary teeth to resorb. Hereditary gingival fibromatosis. Thickened and enlarged gingivae can impede tooth eruption locally. Localized causes. Ectopic crypt position, supernumerary teeth, or odontomes can interfere with tooth eruption. Radiographic examination may be necessary for investigation, especially if there is a delay of more than 6 months between eruption and anti-mere tooth. Treatment. Systemic conditions may require appropriate treatment. Local obstructions like supernumerary teeth or odontomes need to be removed. Surgical exposure and orthodontition may be required for late-presenting permanent canines. Patients with hereditary gingival fibromatosis may need gingivectomy. Included cranial dysplasia, comprehensive treatment planning involving restorative, surgical, and occlusal management is essential. This may include extraction of retained primary and unerupted supernumerary teeth, orthodontic treatment, and prosthetic replacement if necessary. Exfoliation disturbances in dentistry can indeed signify underlying issues that require careful evaluation and management. Let's break down the 2 main types and their associated conditions. Premature exfoliation. Significance always requires further investigation as it can indicate systemic conditions affecting dental development or health. Associated conditions. Hypophosphatasia, a rare genetic disorder characterized by defective bone and teeth mineralization due to low levels of alkaline phosphatase. Severe congenital neutropenia, a condition where the body produces an abnormally low number of neutrophils, leading to recurrent infections. Cyclic neutropenia, another disorder characterized by periodic reductions in the number of neutrophils, leading to recurrent infections. Celiac, Higashi syndrome, a rare genetic disorder characterized by recurrent infections, partial albinism, and neurological abnormalities. Langerhans cell histiocytoses, a group of disorders characterized by the abnormal proliferation of Langerhans cells, which may affect bones and other organs. Papillon-Lefevre syndrome, a rare genetic disorder characterized by palmoplantar keratosis, thickening of the skin on the palms and soles, and severe periodontitis. Delayed exfoliation infraocclusion. Definition, refers to teeth that fail to come into normal occlusion or remain in their relative position while other teeth continue to erupt. Common causes and treatment. Failure of premolars to develop leading to ankylosis of primary molars. Treatment may involve removal of infraoccluded primary molars, restoration of retained teeth, or orthodontic interventions like braces, dentures, bridges, or implants. Other causes of delayed exfoliation. Fused/geminated primary teeth, developmental anomalies where 2 teeth are joined together. Ectopically developed permanent teeth that erupt in abnormal locations. Trauma or severe infection of primary teeth, injuries or infections that affect the primary teeth and disrupt normal exfoliation. Understanding these disturbances and their associated conditions is crucial for providing appropriate dental care and addressing any systemic issues that may be present.